Hello, everyone. Hopefully you all can hear me. So my name is Chris Adams. So we'll kind of go slow here while people still sort of trickle in for the talk. So my name is Chris Adams. I'm the second year neurology resident up here at Boynton Beach, branch of Southeast Veterinary Neurology. So we are going to be talking about the vestibular system, covering anatomy and dysfunction. If any of you attended the SEVN Synapse this past fall, I apologize because this will be somewhat of a repeat. And before we start, just a couple of kind of housekeeping things for you. So you guys will receive an email with your certificate about an hour after the webinar finishes. Rest assured you will get your CE credits for listening and bearing through with me here. And then there are I'm not 100% sure where it is, but you should see a link that you can download some notes that go along with this talk. You're welcome to do that now and kind of follow along there if you want to do it later. It's mainly for you to have as a reference. It goes into a little bit more detail. Unfortunately, there's not pictures and things in there, so it's a bit dry, but it goes in a little bit more detail for those of you that want to maybe take a step more than kind of what we're going to cover here. But the main purpose was also just to have it so you guys can kind of refer back to it if you can't remember something or want to just double check something. So those are available to you. If you can't find it here in the webinar platform, included in that email that you'll be getting following the webinar, there's going to be two PDFs for you to download. So one will be the vestibular notes for you, and then the other is a neuro exams sheet for you to use to kind of fill out and kind of stepwise you through the neurologic exam, which we're not going to necessarily be covering today, but kind of stepwise through that, and just something that if it's an emergent case that you need to send over to us, something you can quickly kind of jot down your notes and what your exam was, and sort of send that with the client, so we have at least a comparison of what they looked like when they were with you compared to what we see, if something may have changed. And it just saves you from having to sit there and type up your notes frantically to get it over to us. Just something nice for you guys to have. So again, those two things will be included in that follow-up email. So looks like there's about 105 people or so here. So we'll kind of move forward. We'll let people kind of continue to trickle in. This is being recorded, and following the webinar, it will be posted on YouTube. So if you do come in a little bit later, it will be posted for you to see. So kind of taking the next step here, so an outline, so kind of just go through what we're going to be covering today here. And we're going to start with basic anatomy and physiology of the vestibular system. And as you can see from this picture, it's quite elaborate. There's a lot of moving parts that go into the vestibular system. I'm going to try to break it down and make it as simple as I can for you, and hopefully just give you kind of the main points of what you need to know. Again, with the anatomy, the main understanding or the main goal of trying to understand some of the anatomy is not to bring you back to first year vet school, but understanding the anatomy will help us when we are looking at clinical cases and we're seeing dysfunction to maybe figure out where our problem might be. And that's essentially what neurology is we're trying to figure out, based on the neuroanatomy and then the clinical signs that the patient is showing, where in the nervous system our problem is. Obviously today we're just going to be focusing on the vestibular system. So we're going to go through structures of the inner ear. We're going to go through the vestibular cochlear nerve, particularly the vestibular division of this nerve. The cochlear portion is kind of another talk, and that would be your hearing. We have the vestibular nuclei within the brainstem, of which there are 4, and then there's pairs, so there's 8 total there. We're going to go through the cerebellum and its role in the vestibular system. And then we're going to go through the clinical signs of vestibular dysfunction. So peripheral versus central, and then also the illustrious paradoxical vestibular dysfunction. And then in there, we'll also talk about kind of bilateral vestibular dysfunction. And then to kind of wrap it up, to hopefully just kind of go through and see if we can kind of assimilate what we've learned here. We'll go through just 3 case examples for you really quickly, and there's some poll questions in there for you to answer. Just to, again, try to put into practice kind of what we've gone over, and then if, you know, trying to apply that, if there's any questions that you may not have thought of just listening, obviously we can address that while we're all here together. So first, the inner ear. So there are 2 main parts of the inner ear. So you have a bony labyrinth, which is located within the petrous part of the temporal bone, okay? And the bony labyrinth contains 3 continuous fluid-filled portions, all right? So they're all connected. You have the 3 semicircular canals, and then you have the cochlea, and those arise from the vestibula. So those are the 3 parts: the semicircular canals, the cochlea, and the vestibula. And again, these are just openings within the bone, particularly the petrous portion of the temporal bone there. You then have the membranous labyrinth. So this is what is essentially encased in the bone, and that is 4 fluid-filled compartments, again, all of which communicate. So there's constant flow between all of these different compartments, and you have the semicircular ducts, you have the utricle, you have the saccule, and then you have the cochlear duct. So those are going to be the 4 main kind of components of the membranous labyrinth, which you can kind of see them over there in the image on the right. Contained within the membranous labyrinth, you have 2 specialized receptors, and this is where essentially your vestibular system is starting. So you have the cristula ampullaris and you have the macula. And the ampulla is a dilation within the semicircular canals at the base of each one. So there's 3 semicircular canals, 3 semicircular ducts with 1 ampulla in each, and then there's a crista in each of these. And the crista and then the macula, and then which are located in the utricle and the sacculae, are essentially the receptors, or the dendritic zone are connected to the dendritic zone of the vestibular portion of the vestibular cochlear nerve. So the crista, again, is at one end of each of the membranous semicircular ducts. And there's on the surface of them, which is, again, you can kind of see it in the images over there on the right, there's a gelatinous structure. And it's composed of a protein polysaccharide that is called the cupula. And overlying, kind of extending into the cupula, are the hair cells of the crista. And there's about 40 to 80 hair cells on kind of that luminal surface there. Most of them are stereocilia, which are modified microvilli. There's 1 single kinocilium, and it's a modified cilium. And that is what, when kind of this endolymph, which is a fluid that is present within the membranous labyrinth, flows, it bends those hair cells, okay? And it's the bending of the stereocilia that's the source of the stimulus to the dendritic zone of the vestibular cochlear nerve. So and then bend, or depending on how they bend, that's when we get increased signal or decreased signal. So that's essentially how your vestibular system works. And the crista in particular are used within dynamic equilibrium, okay? So they are responding to acceleration or deceleration. At constant velocity, it's not moving. And can also help with kind of rotation of the head, being within the semicircular ducts there. The macula, set up essentially the same. There's some slight differences. So the macula has these statoconia, so otoliths that cover the surface. So a lot of people, when you hear about kind of vertigo in humans and kind of the stones have moved and that sort of thing, they're really talking about the otoliths there. And again, essentially the same thing. They have the hair cells that project into this, and movement of that gelatinous and the otoliths is what bends the hair cells, and we're receiving input based on that. And there are two, again, so you have the macula within the utricle, and then you have the macula within the sacculae, and they're oriented differently. So the macula within the utricle is horizontal, and the macula within the sacculae is vertical. And they are contained for static equilibrium or control static equilibrium. So they're more forces of gravity. So whether you move up and down, back and forth, that's when those receptors are working. So the vestibular cochlear nerve, so kind of moving on to the next part of the anatomy here, again, it's made up of two portions. So it's a single nerve, but it's made up of two portions. So you have the vestibular portion and the cochlear portion. The vestibular, which is what we're going to be talking about today, and then you have the cochlear portion, which is, again, kind of hearing. So the vestibular portion, so this is the 8th cranial nerve, is in synaptic relationship with the hair cells of each crista, and each crista ampullaris, and then the macula utriculi, and then the macula sacculi. From there, again, those kind of individual nerves on those hair cells are forming the larger vestibular cochlear nerve, and then they form a vestibular ganglion within the petrous portion of the temporal bone. Okay, and then from there they continue through the petrous portion of the temporal bone into the brainstem, where the majority of them are going to terminate within the vestibular nuclei in the medulla and the pons. There are a few that don't terminate there and course directly into the cerebellum by way of the caudal cerebellar peduncle, and then terminate in the vestigial nucleus and in the cerebellar medulla and the cortex of the follicular nodular lobe. And that's important to remember for later when we talk about paradoxical vestibular disease. Okay. So the vestibular nuclei, and then I see some people asking questions. So there is a kind of a time at the end, so we'll go through all of those. So rest assured, we'll definitely kind of address some of those questions and things there. The vestibular nuclei. So again, there are 4 paired vestibular nuclei, so 8 total. And then in their pairs, they run kind of along the medulla and the pons there. And they are so helpfully named rostral, medial, lateral, and caudal. So as you can see in the diagram over on the right. And they form a continuous column on each side, again, of the pons and the medulla. So right at the base of the cerebellum there within the brainstem. So this is now kind of shifting, and we'll talk about kind of the differences there, but now we're shifting into the central portion of your vestibular system, okay? So from the vestibular nuclei, there's numerous projections into the spinal cord, the brainstem, and the cerebellum, okay? So, and this is how your brain controls your movements of your eyes, your neck, and your trunk, all within the balance or within the vestibular system. So it's a very involved system, and you're receiving, the brain is receiving constant input from your balance system. So when we don't receive that, that's when we get dysfunction. But through these different pathways, again, is how your brain coordinates all of these movements. So if you hear something or start to fall one direction, how you kind of reach out to stop yourself, you look over at what's happening, you turn your head, all of that is being controlled kind of through these vestibular nuclei and through their connections. So your cerebellum is also involved with this. So axons, again, from the vestibular nuclei and the vestibular ganglion project up into the cerebellum. And your cerebellum is used mainly to coordinate movements, okay? So it doesn't initiate movement, but it does help smooth them out, and it does help coordinate them with whatever else is going on. So again, these axons kind of course through the caudal cerebellar peduncle, which will be important later. And then they terminate in the cortex of the flocculus of the hemisphere, and then the nodulus of the vermis, also known as the floccular nodular lobe of the cerebellum, okay? And then there are collaterals that extend into the vestigial nucleus. So this is a very intricate and very well connected system. And again, this helps coordinate positions of the eye, neck, trunk, and limbs with the position and movement of the head. So that's why there's all of this involvement. And again, everything, all of those types of movements are being routed through the cerebellum, which is why all of this can be coordinated through there. So some clinical signs of vestibular dysfunction. So we can have abnormal posture. So the vestibular nuclei are projecting neurons down the spinal cord, and they're controlling the extensor muscles and the flexor muscles. So in particular, on the same side, or the ipsilateral side, they are going to facilitate or be facilitatory to the extensor muscles and inhibitory to the flexor muscles on that same side. But they also have collateral, so they're going to send it to the other side of the spinal cord, where they're going to be inhibit the extensor muscles on the opposite side. So the way that I help myself remember this is, if you're falling, it doesn't help you very much if you're falling and you stimulate your flexors, because it's just going to aid in your falling. So what your body does is it stiffens that side of your body, right? So if you're falling, it's trying to push you back on balance. So it also doesn't help if it's going to be facilitatory to the extensor muscles on the opposite side, because then you're just going to push yourself back and forth. So that's just one way that I remember kind of what it's inhibiting and what it's trying to facilitate. But when we see dysfunction, we obviously have an abnormal posture. And posture is different than ataxia. So posture would be something like a head tilt or falling over to one side. Ataxia is an incoordination. So they will, when they're trying to walk, it's not coordinated. And again, that comes from all of these connections of the vestibular system routing through your cerebellum. You can see a nystagmus. So there is a normal physiologic nystagmus that we test for, and then you can have abnormal nystagmus. And it is very important when you're looking at vestibular dysfunction to look for a normal nystagmus, look for an abnormal nystagmus, but even if you don't see one, it's important to challenge the balance system, which we're going to talk about, to see if they have a positional nystagmus. So resting or spontaneous nystagmus is the patient that comes in, obvious sign of a head tilt, they're acting off balance, and when you look at their eyes, they have a rapid eye movement. So that would be a resting nystagmus. Positional would be, hey, when I look at the patient, I don't see a nystagmus, but if I challenge the balance system by shaking their head, covering their eyes, or flipping them on their back, we then can induce a nystagmus, which is still abnormal. That would be a positional nystagmus. You then have strabismus, which again, you can have kind of a resting strabismus, but you can also have a positional strabismus. And strabismus can be a little bit tricky because it is coordinated with your vestibular system, and any abnormal or strabismus is abnormal. But when you are looking at the strabismus, you have to kind of piece it together with what else you're seeing, because we have other cranial nerves that control the extraocular muscles that can also cause a strabismus. So a strabismus does not always indicate vestibular dysfunction. And for those of us in either small animal, and if you happen to have to look at a large animal, or for those of us that might have worked with large animals and are kind of making that shift over to small animal, there's slight differences here. When you lift the head of a small animal, their eyes should remain in the middle of the palpebral fissure, okay? So if it doesn't, that would be abnormal. So that would be a strabismus, usually kind of ventral. a lot of times with the vestibular dysfunction. Cows are not the same. So large animals are not necessarily the same. So cows and other ruminants. When you lift their head, they will often not bring their eyes up into the middle of their palpebral fissure, and that is normal for them. So if you see that, if you're a small animal person and you happen to be looking at a cow or something for a friend, and you see that, that does not necessarily indicate vestibular dysfunction, because again, it can be a variation of normal for those species. We then have postural reactions, which we'll talk about kind of when those play a role in vestibular dysfunction. We'll then talk about bilateral vestibular system disease, and then again, kind of touch base on paradoxical vestibular system disease here at the end. So, abnormal posture. So there's loss of coordination between the head, the neck, the trunk, and the limbs, as seen in a head tilt. So, and that is when you look at the patient, one ear is lower than the other. It really helps when they have nice erect ears, but you can also look at them. So sometimes it's helpful if you look at them from behind. So stand behind your patient with him kind of facing away, and you can sometimes see the head tilt a little bit easier. Other times you kind of have to look ahead of them, and you're looking at their eyes, and are they tilted to one direction? Some are more obvious than others. You know, the dog that comes in and his head is almost at 90 degrees is a little bit easier than some of those dogs that have a real subtle head tilt. They may fall or lean to the side of a lesion. So in the lower video, you can see the dog kind of leaning up against the wall. He also has a slight kind of titubation or truncal sway, which can also indicate balance system dysfunction. You can kind of see him shifting his weight back and forth. The video in the top here is kind of demonstrating the last two bullet points here. So in some cases, the neck and the trunk may flex laterally, with the concave side occurring ipsilateral to the lesion, to the same side. And this patient on the top, if you stopped him from circling, he would still have this kind of body turn to the right in this sort of C-shaped. And he is obviously, as you can see, also circling in this video. And they will often circle, more often than not, circle to the same side of the lesion, right? Which is opposite of kind of when we're talking about proprioception for brain disease, they too will circle to the side of the lesion. But the main difference between the two circlings is the tightness. So more often than not, as you can see demonstrated in this Yorkie, when they have vestibular dysfunction, they are circling tightly, okay? For brain disease, which also can cause a dog to circle, those dogs will tend to circle kind of around the perimeter of the room. So they tend to have more wide circlings than dogs with vestibular dysfunction. You can have dogs that are very severely affected, and they can be non-ambulatory, so they can't walk because they're so off balance. And some dogs will also do what we call alligator rolling, and they'll kind of roll to the side of the lesion because there's so much dysfunction there. A lot of times dogs that have peripheral vestibular dysfunction, if they are that off balance where they're kind of alligator rolling, that will typically improve in about 24 to 48 hours once the balance system starts to adjust. Doesn't mean they're necessarily getting better, mind you, but the balance system is adapting. So, quick question. So first poll, so what are the 3 different types of ataxia? So kind of our answer choices here are spinal, cerebellar, and vestibular. We have cerebellar, vestibular, and proprioceptive. And then you have proprioceptive, vestibular, and spinal, and proprioceptive, cerebellar, and spinal. So I'll give you guys a couple minutes to kind of go through and see what you think, and then we'll go from there. Looks like we're about 50% voted so far. All right, we're at about 70%. So looks like the majority, so we have 30% for A, about 54% for B, 9% for C, and about 8% for D. So the correct answer would be B. So the three types of ataxia there are cerebellar, vestibular, and proprioceptive. And you know, the differences between cerebellar and vestibular can be quite difficult sometimes. Cerebellar ataxia often will be accompanied by high stepping, so they're overreaching. You can also see things like the intention tremors, so think about your little kittens with cerebellar hypoplasia. Vestibular ataxia, they essentially look like somebody who's drunk, so they're falling over to one side, they're crisscrossing their legs, so that's a very classic kind of vestibular quality ataxia. And proprioceptive ataxia would be your very classic T3L3 dachshund, you know, that walks into your office, is, you know, happy and bright, but kind of stepping over themselves in the back legs. You know, they're sort of crossing midline and kind of their back legs are getting tangled in themselves. That's proprioceptive, and that's because they're not receiving, the brain isn't receiving the input from the back legs to say, hey, this is where my legs are, so it can't be coordinated appropriately. So good job. So ataxia. So again, the three different types of ataxia are proprioceptive, vestibular, and cerebellar. And you can see in this case, this dog has what I would call it an actual cerebello-vestibular ataxia. So he's got this truncal sway. You know, he's wide-based in all four legs there, mostly in the thoracic limbs that you can see kind of most obviously. He does fall over to the side to the right there, and you can kind of see how he's kind of sort of drunk walking there as he makes his way to the window. So a lot of times we do have a crossover between the two, depending on where the lesion is. And again, patients with vestibular ataxia use their eyes to help maintain balance. So if it's really subtle and you can't tell, if you blindfold the patient, it may get worse. So a lot of times you'll see dogs and they're looking at the ground as they're walking, and that is because they're trying to coordinate that with their eyes. So they're kind of watching where they're stepping, right? So again, like a drunk person, right? You kind of stare at your feet and you're wanting to make sure you know where they are when you kind of step forward. Be careful if you do blindfold them, because it may make them significantly worse. So with big dogs and things, you can get hurt. Be extra careful if you do this with a large animal. So, because obviously if, you know, you do make them worse and then they start to fall over, we don't want somebody to get hurt. And you can kind of tuck a blindfold underneath the halter to kind of cover their eyes, but never tie it to the halter, because again, if you can't get near them because they're so off balance, you know, they may fall and hurt themselves or hurt someone because they're not sure where they're going and what they're doing. So just a word of caution there for those of you that may end up doing an exam on a large animal. Nystagmus. So again, there's a normal physiologic nystagmus, okay? And that is what we test by kind of lifting the dog up. So some people call it the oculocephalic reflex, and you move the head side to side, and the eyes should kind of track and follow with you. That's normal, and that should be present when an animal is manipulated. And with small animals, you can kind of, you know, ones that you can hold, you can sort of lift them up and move them side to side and see that. Other times with big dogs, you know, we'll often kind of move their head side to side and look at them that way and get the tracking. An abnormal nystagmus would either be a spontaneous nystagmus or a positional nystagmus. Okay, so again, to kind of go over, the two different types of nystagmuses there, or at least spontaneous and positional. So spontaneous would be the patient that walks in and you can see it. You haven't done anything, but they just have a nystagmus because their balance system is so off. Those patients that don't have a nystagmus when they walk in, but you flip them on their back, or change their position or challenge their balance system in some way, and then you notice the balance or the nystagmus, that would be a positional nystagmus. Both are abnormal. There's 3 different types of nystagmus. Okay, so you have horizontal, which is and these are jerk nystagmus, I should specify. And horizontal is the twitching of the back and forth, right? Kind of most classic and ones that most of us have probably seen. You then have rotary, and a rotary nystagmus is where the eye is kind of twitching back and forth. So when I talk to clients, think about it like a clock hand kind of twitching or going from 12 to 1 and back. Most easily seen in large animals with their horizontal pupils, and cats with their vertical pupils, just because you can see it a little bit easier than dogs sometimes, which have the round pupil. So it just makes it a little bit harder to see if you can't kind of see their the sclera there. And then you have vertical nystagmus, which is a true up and down. Disorders of the peripheral vestibular system, the quick phase of the horizontal or rotary nystagmus will be directed away from the lesion, okay? And that's important because conceptually, when we describe a nystagmus, so if you're calling to refer a patient over to us and you're thinking that they have a balance system problem and you tell us, hey, they have a horizontal nystagmus, and we're gonna ask, well, to what direction? And when we say that, we're wanting to know where the fast face is. Or if we're talking and giving you an update on one of your patients and we say, hey, they had a horizontal nystagmus with a fast face to the horizontal nystagmus to the right, is often what we'll say, and what we're describing is the fast phase. And the fast phase is to the normal side. So, and that's because that's the quick or the recovery phase. So the eyes are going to abnormally kind of drift to the side of the balance system that's wrong, and then their other side that's normal is going to correct it. So then you get this kind of twitching back and forth. So slow phase towards the lesion, fast phase away from the lesion, but we describe it by the fast phase, okay? Disorders of the central components of the vestibular system, the nystagmus may be any of the 3, so horizontal, rotary, and vertical. With peripheral, they're horizontal and rotary, and may change direction based on position. So if you have a dog that walks in with a spontaneous horizontal nystagmus, but you put that dog on its back and it goes vertical or goes rotary, that would suggest a central vestibular dysfunction, okay? And the nystagmus may be directed away or towards the side of the lesion with central. So that's, again, an important distinction and something that we're going to cover here in just a little bit. So we have these kind of examples. So in this cat, kitten presented for hydrocephalus, and he has a spontaneous vertical nystagmus. So you can see the kind of the twitching up and down of his eyes. He's got quite an obvious one, which made it nice, but that is a vertical nystagmus. The husky down there at the bottom, he has, it's really a rotary nystagmus. It's quite difficult to see exactly. So he was a classic example of, he came in with a horizontal nystagmus, we put him on his side, and then he developed a rotary nystagmus. So he's kind of in the process of switching there. It was made worse by changing the position. So that's kind of what that may end up looking like. And then this next one, and I do apologize if it doesn't come through earlier in the practice session, the internet wasn't being very nice with the slow speed here, but This one is a classic, it's again a rotary nystagmus. This one was hard to see because of the corneal changes. But if you look really closely, when the dog blinks, if you kind of look at the sclera, he blinks and you kind of miss it. But if you look at the pupil there, you can notice, so he is kind of rotating to the right, which is where his head tilt is. And then when he blinks, it fast phase corrects to the left. So it was just to hopefully try to show you what a rotary nystagmus is. And again, I apologize if it doesn't quite come through because of the internet there. But so 3 kind of examples for you of what the different nystagmuses could look like. So strabismus, again, the strabismus is defined as an abnormal position of the eye when compared to the orbit or the palpebral fissure. So this dog has a resting strabismus, as you can see in the right eye. That's very abnormal there compared to the left. And again, when the head and neck are extended, the globe should remain in the center of the palpebral fissure for dogs and cats. So this may not be the same for large animals there. And again, the strabismus is a difficult one because it can mimic ocular motor dysfunction. And the way that you're going to look and kind of differentiate between those two, at least in the motor portion there, would be your normal physiologic nystagmus. So do they have one or not? Because that is testing your ocular motor dysfunction or ocular motor function. The other portion of the ocular motor nerve would be the parasympathetic, which is the innervation of the pupil. So your PLR is going to also help you. So, everything is kind of tied together there. But just be careful if you don't see any other signs of balance problem, but you see a strabismus, there may be something else going on. It may not be true vestibular dysfunction. It may be, and they may be compensating, but keep your mind open that there may be other cranial nerve deficits that are giving you the strabismus rather than just pure vestibular dysfunction. So again, with a vestibular strabismus, the strabismus will be on the same side as the vestibular dysfunction. Okay, so right-sided lesion, right-sided strabismus there, and often it'll be positional. And we can see a strabismus even with peripheral. So just because you see the strabismus, again, doesn't necessarily mean that it's a central lesion. So because we can see them with peripheral dysfunction. So and they're just a reminder about the farm animals. So postural reactions. Okay. So this is the big one when you get to this one of helping us localize and differentiate between the two as far as peripheral and central. Okay, so the vestibular system, the peripheral vestibular system, is the only system involved with movement that does not interfere with postural reactions. Okay, so if you can have a dog that is very, very off balance, or cat that is very, very off balance, that's rolling and falling over, but if you can get them to stand still and support them appropriately and test their proprioception, they will not have absent proprioception or any sort of deficits in their proprioception with a pure peripheral vestibular dysfunction. Okay. So there's different ways that we can test postural reaction. So proprioceptive placing, so that's your paw replacement. So where you're supporting the animal, flipping the paw over, and they should immediately correct that. Again, be careful and make sure that they're very well supported, because if they're, let's say for sake of example, you have a dog that, a Labrador, a largish dog, and they are off balance to the right. Be careful, when you're supporting and flipping the right side of them over, because they're already feeling like they're falling to the right. So if you don't have, support of them, then they either one may leave it because they don't feel confident enough to pick up and replace it if you're not supporting them appropriately. But also if you're not and they're very off balance, as soon as you take that away, they may try to fall and just don't want yourself or the patient to get hurt. You can also test proprioception with hopping, and again, be very, very careful with a large breed in doing this when they're off balance already, and that's kind of knocking them off balance and kind of watching them hop with you. So again, just be very, very careful when you're doing that with a dog that has vestibular dysfunction. You could do placing response, so tactile placing and visual placing. So tactile placing, often see us do it with cats or very small dogs. So you lift them up, bring them to the edge of a table or a chair, a counter, and then as soon as they touch it, they should put their paw up on top of it, right, to kind of brace themselves. Be careful when, especially with cats, when you pick them up, if they have vestibular dysfunction, because they're adjusting, the balance system is adjusting by their touch, right? So if they're on the ground and you pick them up, they might freak out and they're going to come out claws out. So just be very careful when you do that. Go slow, just so they don't, again, so no one gets hurt there. And then visual placing, so tactile placing will often, to kind of differentiate between these two, tactile, you're covering the eyes so they can't see, and it's truly when they touch, they place. But visual is doing the same thing, but with their eyes uncovered, and as you approach it, they should start to reach out for the table or the countertop before they've actually touched it. So, and that's again, if they know exactly where their limbs are there. They should do that. You have hemi walking and you have wheelbarrowing and extensor postural thrust as well. But again, you know, you're lifting a portion of these animals, so just be very, very careful when you do that to make sure that you're keeping them safe and that you're keeping yourself safe. And you know, even though it's not directly related to postural reactions, just a note, when you are moving these patients, be very, very careful. And what we'll tend to do is you want to tuck and kind of hold them pretty tight. And whatever side of you think that their balance system is dysfunctional on, so again, for sake of argument, let's say it's a small dog or a cat with a right-sided lesion. If you need to move them for any sort of reason, pick them up slowly and make sure their right side is against you. Okay, so if you pick them up on the left, and this is also important to coach your owners, because if they're very off balance and they're falling to the right, if you pick them up and put the left side towards you, they may have a tendency to push away and kind of, because they're trying to fall to the right. So they may just roll right out of your hands or your arms. So it's important. And obviously it depends on the dysfunction, so use your judgment, but you know, if it's right-sided, I tend to have their right side against me, so they're kind of leaning into me, and then I just sort of have them wrapped and tucked. If you're having trouble, if you really need to get the postural reactions and you're having trouble, what also can help is have someone support them and then have someone just hold their head kind of between their temples there and just hold steady. And that sometimes will help keep them on balance to allow long enough to allow you to do the postural reaction. So that's another way that you can try to get this done without them sort of flailing and falling if they're very, very dysfunctional. So some unique syndromes. So we have bilateral vestibular dysfunction and we have paradoxical vestibular dysfunction, okay? So bilateral vestibular dysfunction, you're gonna have wide head excursion. So we kind of joke and call it the Stevie Wonder. So they're kind of drifting and throwing their head from one side to the other. You will not, and this is very, very important, that you will not get a normal or abnormal nystagmus with bilateral vestibular dysfunction, okay? Because both sides are wrong. So there's no good side, there's no bad side. So the brain doesn't know what to do. It's receiving appropriate, so it's kind of not, I guess it should say it's not receiving information from either side, so it can't differentiate that, hey, this side is wrong and this side is correct. So when you do the normal physiologic nystagmus, again, it's because both sides are dysfunctional, it's not measuring that the head is being rotated or moved. So you're not going to get the normal, normal physiologic nystagmus. And again, because there's no side that's worse you're not going to have your abnormal nystagmus. So if you see that, but you don't get a nystagmus, don't be fooled. There's also a special test, and be very careful when you do this one too, especially if they're laying on the ground. It's called a head rebound phenomenon. So this one, you lift the head up and you take away the support. And in a normal dog, they should catch their head, right, and not let it fall. Well, dogs and cats that have bilateral vestibular dysfunction or cerebellar dysfunction, so it's not a perfect test to kind of differentiate between vestibular and cerebellar there. Because you can see it again with kind of bilateral inner ear disease, giving you bilateral vestibular dysfunction. They'll drop, and just make sure that you have your hand there so they have something soft to lay on, or a pillow or something, because they will let it drop all the way to the ground. So that's another test that you can do if you're thinking or suspicious of bilateral vestibular dysfunction there. And I'll play this video. So this is a cat with those wide head excursions. So see how he kind of throws himself all the way to the left and throws himself all the way back over to the right. So again, we kind of joke around and call it the sort of Stevie Wonder. So paradoxical vestibular dysfunction. So this is the one that trips everyone up. And this one is where the head tilt and the loss of balance are directed toward the side opposite of the lesion. Okay, so with these dogs and cats, they will come in and they will look like a classic vestibular animal. But go through your neuro exam and you do all of the tests. You have your nice, maybe a horizontal nystagmus, fast phase is to the left, head tilts to the right, they have a strabismus, like everything seems pretty classic and all hunky-dory. And then you go and do your postural reactions and they have deficits on the left side. And you're like, well, this doesn't make any sense, right? So head tilts to the right, they're falling to the right, like everything else fit with a right-sided lesion. The legs never lie. So if you're getting postural reactions on the left side, but everything else is to the right, then you have a case of paradoxical vestibular dysfunction. So it is a central lesion. You're not going to get this with peripheral vestibular disease. So it is a central lesion, but and this is where you can sound real great to the owner, because you know exactly where the problem lies. It has to be in the caudal cerebellar peduncle, the floccular nodular lobe of the cerebellum, and some people say both of, or certain vestibular nuclei, but those are where it's going to be. And the reason that we have the head tilt and the loss of balance towards the opposite side is because the axons that are traveling in those areas are inhibitory. So if you're losing your inhibition, right, on one side, it's receiving more input from that side, even though it's the abnormal side. So you're getting lots of input from this side, not so much input from the normal side, where your brain reads that as normal, abnormal, head tilt, falling, all of the other rules apply to the side that the brain thinks is weaker. The reason that you get your postural reactions is because your proprioception is traveling through those same areas to go up into the cerebellum, because your proprioception, you have conscious and unconscious, which we can't actually differentiate the two on our exams. But you have your unconscious, which goes up into your cerebellum. You have your conscious, which goes, to the forebrain there. So you're hitting those tracks as well, but those are going to be ipsilateral. So that's why with paradoxical vestibular dysfunction, head tilt to and loss of balance to one side, but postural reactions are going to be on the opposite. But when in doubt, always go with the legs, because they're not going to lie to you. All right, so we got about 10 minutes left or so, so we'll kind of go through these examples here. So there's going to be questions, so we'll go through a quick neuro exam. Okay, so it's a 2-year-old male neutered domestic short hair, comes in, he's bright, he's alert, appropriate mentation, he's ambulatory with a tendency to list to the right or kind of fall to the right, mild cerebellovestibular ataxia, and a right thoracic limb hypermetria. So he's kind of overreaching in that right thoracic limb. Cranial nerves, mild to moderate, head tilt to the left. Absent paw replacement in the right thoracic limb with delayed paw replacement in the right pelvic limb, and normal paw replacement in the left thoracic and pelvic limbs. Absent hopping in the right and pelvic limbs with delayed in the left. Okay. Normal withdrawal reflexes, and he appears comfortable. So, given all of that, and I'll let you kind of, we'll leave it up for a moment and kind of go through that. So, you know, look at what we're seeing here, and then what you're seeing for the proprioception. All right, hopefully everyone got it. So where do you think our problem is? Just over 50%. Go for a little bit longer, got about 10 seconds to a minute, and then we'll go through it. Okay, so it looks like we have 51% for A, 23% for B, 16% for C, and 11% for D. So with this one, the fact that we have proprioceptive deficits, right? So there's delayed hopping and delayed proprioception. We know that it can't be peripheral, right? So peripheral wouldn't interfere, assuming that we have a single lesion causing both. The proprioception would not be involved with proprioceptive deficits would not be involved with peripheral vestibular disease. But we have the head tilt to one side. We have our proprioceptive deficits on the opposite side. So he was right central vestibular. And this was a young cat with a presumed cerebellar abscess there. But good job. So he was right central vestibular, but paradoxical. All right, the next one is an 11-year-old female spayed miniature schnauzer, bright and alert with appropriate mentation, ambulatory with a moderate vestibulocerebellar ataxia and listing to the right. He had a mild head tilt to the right with a subtle horizontal nystagmus with a fast phase to the left. Remainder of the cranial nerves were normal. He had absent paw replacement in the right pelvic limb with normal paw replacement in the thoracic limbs bilaterally and the left pelvic limb. Normal reflexes in all four limbs and was comfortable. So next question, where do you think his lesion was? So I'll give you a second really quick to read through the exam, and then we'll go on to the question. Where do you think his question or his problem is? All right, we'll go for 30 more seconds. Okay. All right, so again on this one, so we had proprioceptive deficit, which means we can automatically, just simply based on that, we can rule out peripheral and so C and D, right? So can't be peripheral if we have proprioceptive deficits. So then the question is it right central or is it left central? And it was right central. So this one being a Schnauzer and his age, but the MRI findings, I don't know if you can see it, kind of a, and I don't know if my pointer is coming through, but this nice kind of triangular shape, hyperintensity here within the rostral cerebellum. This is a classic rostral cerebellar infarct. So what are the most common areas that we'll see an infarct or a stroke there? So good job. So this last one, so we have a 2-year-old female spayed miniature poodle mix, bright and alert, appropriate mentation, ambulatory with vestibular quality tetraataxia, no appreciable weakness, mild left-sided head tilt. Cranial nerves, again, the left-sided head tilt, normal menace response, normal palpebral reflex, and PLRs bilaterally. Left positional strabismus, so when we flipped him on their back, she had a strabismus, and a positional rotary nystagmus with a fast phase to the right. Normal paw replacements in all 4 limbs, spinal reflexes were normal, and she appeared comfortable. So give you a couple seconds to kind of read back through that, and then we'll go on to where you think her problem is. All right, so. All right, 30 more seconds. Okay. All right, so for her, we didn't see any obvious proprioceptive deficits. So although you can't fully rule out a central lesion, her localization would tend to be peripheral. So then again, are we going to the left? Are we going to the right? And we would say left. So most of you have localized her the same as I did when she first presented. But wonder if I tell you that she represents to me 9 days later after having a seizure. Would you change your answer? So Piper ended up having autoimmune encephalitis, and she ended up having central vestibular disease, and it had progressed and had ended up in her forebrain as well. So she kind of had a multifocal localization there. The reason that I bring this one up is because of this study that came out in 2020. So they looked at 93 dogs, 62% localized central, and 31 localized peripheral. They did an MRI, and following that, 61 out of 62 dogs that were localized central were actually central. Okay, so there was a 98.4%, where 98.4% of them were correctly identified. All right. However, 24 out of 31 dogs were correctly identified as peripheral. So we were only 77.4% correct when localizing peripheral. So I bring this up because we are very good at localizing central, right? If you have a dog and you are localizing it central, the odds of you being right are much higher. If you have a dog that localized peripheral, I mean, the majority we're still correct, right? But there is a higher tendency for us to miss those. And that's because your balance system is very, very adaptive. So they may have gotten over the worst of it. It may have a central lesion that's not, it's in a certain area that is just not simply not affecting the proprioception. And they had a rotary nystagmus or a horizontal nystagmus. So the reason that I bring this up is because it's like you send us a dog and you're convinced that it's peripheral, and we end up doing an MRI and finding a central lesion. Doesn't mean that you're wrong. Doesn't mean that you missed anything. Just means that unfortunately sometimes even us, we have a dog localized as peripheral. There's no centralizing signs, and yet they have a central lesion. So, any case, whether it's you think that it's central, whether you think that it's peripheral, is always worthwhile a referral, because you never know, and it's also why even with peripheral cases, we are recommending MRIs, and it's because of this, in that we could be missing a central lesion, even though they do localize peripheral. So you also see in our discharges, hey, they localized peripheral, but we can't fully rule out a central lesion. So just for some of you that may not know, we do have our Jupiter branch open with Dr. Seneca. So she is open Tuesday through Friday. So if you guys have any questions, anything like that, and you're in the neighborhood, don't hesitate to give us a call. Again, we're here to serve you also in Boynton and down in Miami as well. So, but just wanted to put you out there, and they are located kind of within the Jupiter Pet Emergency and Specialty Center up there. So I know we ran over, and I do apologize, but does anybody have any specific questions that they would like me to answer now? And then let's see. So somebody asked, what is the difference in the treatment when it is peripheral and central? It's a good question, and it really depends on what the underlying cause is. So, symptomatic care. So let's say you have a client that doesn't want to be referred, or for whatever reason that may be, meclizine is great, whether it's central or peripheral. It helps them feel better. If they're vomiting, which is not super common and not as common as you might think with dogs and cats with vestibular disease, but if they have vomited or they're not wanting to eat, you can give them Cerenia. And then it's kind of playing the odds, right? So looking at the breed, are we thinking that it's a middle ear infection like in a Cocker Spaniel? Again, not that they can't have central lesions, but are we going to kind of again, statistically, hey, they're more likely to have this, so we trial antibiotics, or a CAVI with their primary secretory otitis media. Are we going to try antibiotics and see? You can have middle ear disease that has actually crossed through and caused central. So sometimes we're treating central vestibular disease with antibiotics. Oftentimes, I would say that we're reaching more for steroids for central, even in the face of an infection, just to help reduce that inflammation, because they do have kind of a meningitis that can be contributing to this. If it's a stroke, there's nothing we can do necessarily for the stroke itself. We just give them supportive care and wait for their body to heal. We then look for reasons why they may have had the stroke, but for the treatment of the stroke itself, there's not much that we can add to that. We may have, again, autoimmune meningitis, which we're treating, differently. So it really depends on, I'm sorry, I'm not really answering your question directly, but it's kind of a hard one to answer, because it really depends on what the underlying cause. So the golden rule with neurology, whether it's vestibular, whether it's forebrain, whether it's, and it's spinal cord, it's the disease itself, or it's the location within the nervous system, not the disease itself, that gives us the clinical signs. Okay, so an infection in the brainstem is going to give you the same signs, potentially as a meningioma in the brainstem, or a stroke in the brainstem, or autoimmune meningitis, or a spinal tumor is going to give us the same signs as a disc rupture. So it doesn't help us just to go off the signs to say, hey, this is what it is, because this is what it looks like. Again, it's because anything that goes wrong in that area is we're going to see similar questions. So let's see, any more here? Okay, let's see. So I hope I answered your question. If you didn't, you can always feel free to shoot us an email, and more than happy to kind of expand on that. Or you can always give us a call here in the Boynton location. Oh, you're welcome. Thank you. It is quite a confusing topic, so I appreciate all of you that have kind of stuck it out with me here. The other question that I have here is, do you find that dogs with more ominous lesions have slower nystagmus in general? So no, often actually. So I guess a short answer would be yes. A lot of times the kind of dogs that seem more off balance and you're like, oh my gosh, this looks terrible, are peripheral compared to central. But you may be hitting these dogs, in some cases where they're already starting to compensate. So I've seen dogs that, the nystagmus is very, very subtle, and they do have a middle ear infection, and then other ones have a central lesion. So the nystagmus and the rolling are the first two things that are really going to improve. So if, let's say you have a dog, nystagmus looks terrible, you hospitalize overnight, the nystagmus looks better the next day, doesn't necessarily mean that they're healing. It just means that their vestibular system may be compensating. So I wouldn't localize just simply based on that, but kind of what we see here in the clinic, yes, I would say the dogs that look terrible tend to be peripheral, but it's not hard and fast by any means. What antibiotics would you use? So oftentimes everybody's a little bit different with this. If it's the first time, and I'm suspecting a middle ear infection, or I have, MRI evidence of a middle ear infection, I personally reach for cefpodoxime, and seems to get a lot of them. Obviously, if this is recurrent, then I strongly advise them to either go see a dermatologist. Not all of us here are comfortable with doing a myringotomy, or in really bad cases, I will refer them to a surgeon to have a TICA performed. Especially these dogs, and I've seen a few now Frenchies and English bulldogs that have kind of these otogenic abscesses that have just sort of expanded through the bulla and into the surrounding musculature. But I would say first choice, for me personally, and for a couple of the other doctors here, is cefpodoxime. I also like it because it's once a day, and that seems to work pretty well for the most common bacteria isolates there. So hopefully that answers your question. The next question is, why the dog with rostral cerebellar infarct had normal postural reactions in the thoracic limbs and abnormal in the pelvic? It's a good question. So it's hard. So whether, it was just hitting those tracks for the pelvic limb, because they do run in different tracks. So and it just didn't happen to affect the thoracic limbs. Had they already compensated? Was it subtle, and was it missed? So there's a lot of possibilities there. But my guess is where the infarct happened, it just so happened to spare the thoracic limb proprioception. But I don't have a specific and direct answer for you, so I apologize for that. And then the last one that I can see here, what is the most typical or common presentation of otitis media neurologically? So the most common would be honestly a dog with localizes peripheral vestibular, but also has facial nerve dysfunction. And that's something that we didn't necessarily cover here, but the facial nerve it courses kind of through the middle ear there, so it can be susceptible to infection. So a lot of times when we have a really severe infection, I will see both, they localize peripheral, but they also have facial nerve paralysis. So that side of their face is drooping. They don't have a palpebral because they can't close their eye. They don't have a menace because they can't close their eye. And you may see some kind of dry eye there. So I would say that's the, a true kind of otitis media that's causing a lot of these problems. They'll often present with both. And a tricky little thing with cats, as always, is that they are more likely to have peripheral vestibular dysfunction with with Horner syndrome, because their sympathetic trunk ends up running through the middle ear next to the facial nerve, instead of, so dogs it's kind of, facial, and then oh my gosh, the sympathetic trunk. So dogs tend to have facial paralysis, cats tend to have Horners. So if you see a cat that has Horners, it could also be an otitis media there. So that, I would say that that's kind of the most common thing that I see. Can you have the slides? Yes, I'm happy, to send them if we're okay. That's not a problem to me. Obviously the videos and stuff won't necessarily work. It's too big to email, to be all honest, but I can save it as a PDF so you can at least kind of see the images and that sort of thing. So I'm happy to do that and have it sent out with the notes. And just as a reminder for those of you that may not have been here at the beginning, but there is some notes for you to download that you can download now, or will be received in your email follow-up. That just kind of goes through all of this stuff too, is in more of a kind of bulleted form there. And then the last question that we'll go through today, what do you think of Otomax products for ear treatment? I'm perfectly fine with Otomax products, except when there is middle or otitis media or interna, because we cannot guarantee that the tympanic membrane or eardrum is intact. So I would prefer to avoid anything topical. You can use your Baytril, which is okay, and it doesn't seem to be toxic to the inner ear. But in all honesty, I try to avoid putting anything in the ear when we think that we have otitis media. Flushing it out and kind of cleaning it out is fine, but be very careful, because I have seen it, unfortunately, more than once, where dogs come in and they have otitis media, and they've actually gone deaf because of ototoxicity from a lot of those topicals. So in my opinion, I would avoid it, just to be on the safe side. We can just have the owners kind of cleaning it out just to remove that sort of buildup. And let's clear the otitis media, and once they're looking better there, odds are their membrane is, the eardrum is healed, and then we can try topical if we need to, but I err on the side of caution and just tend to avoid them. But otherwise, I think if there's no evidence that the eardrum is ruptured, I think they're great products and use them, myself. I think that's the last question. So someone just gave us their email address. So again, if you have any other questions, don't ever hesitate to give us a call. Over here at Boynton, the number is 561-736-7736. So that's 561-736-7736. I'm happy to have a chat with you about a case, or you can email us your questions, and we'll definitely try to get through those. Hopefully you guys enjoyed it. Sorry we ran a bit over. Hopefully it doesn't script anyone else's day too much, but I appreciate you hanging out with us and listening. So